This is the second in a series of conversations about the Atlas clinical trial with Julia Woodman. And Atlas, just as a reminder, is the second of two large clinical trials demonstrating the effectiveness of one-to-one Alexander lessons on chronic musculoskeletal pain. The first one was the A-team trial, which looked at chronic back pain. And today we're going to be finding out from Julia about the main findings from the Atlas trial. And perhaps you could start by just outlining those.
Yes, so Atlas demonstrated long-term benefit of Alexander lessons for people with chronic neck pain. And if we look at these main findings in this slide here, in this first slide, what you're looking at here is the change in the main outcome that we talked about last time, the Northwick Park Neck Pain Questionnaire. It's abbreviated here to MPQ. And so you're looking at the change from the beginning of the study to the end at 1 year. And you can see sort of comparable reductions in pain and disability for both Alexander lessons and acupuncture by 6 months after the start of the lessons or sessions, and this benefit being maintained to 1 year. And this reduction in pain and disability was about 30% for the two interventions. You probably notice here there's a more rapid initial decrease in the MPQ score for the acupuncture group, and this is really likely to reflect, at least in part, the more direct effect of acupuncture on pain. And you'll also notice there's a reduction in the MPQ score in the usual care group. This actually is not surprising. You'll see it in pretty well every clinical trial, and it's partly because people are tending to get better over time anyway. And this tendency towards people generally getting better over time is one of the reasons why it's so important to have a control group, so that you're able to take this into account. There's another potential reason for improvement in the usual care alone group, and that's that when any patient is enrolled in any clinical trial, the GP will need to review their case in order to do that. And so in that review, they might then become more active again in the person's management. But importantly here is that the reduction in the pain and disability for the Alexander and acupuncture groups is bigger than it is for the usual care. And we're going to look at that in the next slide. But this reduction is considered as clinically meaningful because it's more than the 25% threshold that's widely accepted as denoting clinically meaningful, whereas the usual care group isn't. So if we turn to the next slide, and what we're seeing here is the comparison with the usual care. So this is actually the main outcome of the trial. So we're looking at the difference in the MPQ score at 12 months, reduction at 12 months between the intervention groups and the usual care group. And we're seeing statistically significant differences in the change in MPQ score from usual care for both Alexander and acupuncture. And this is sustained benefit because remember, this is more than 6 months after the lessons or sessions had been completed. So in other words, both Alexander lessons and acupuncture lead to significantly more long-term benefit than is achieved with usual care alone. Now, what we're seeing here is what is called an intent to treat analysis, which is the usual analysis for any clinical efficacy trial. And an intent to treat analysis includes the outcome data for all participants, regardless of whether or not they attended all of their intervention sessions. And it's got to be this way around, really, because if you're going to get an overall picture of an intervention, so let's take the example of maybe a new pharmaceutical drug that's really effective, but also makes you really ill, so that half the people actually drop out of the trial. Now, if you did only look at the outcomes for those people who completed the trial, you wouldn't really get a meaningful picture of how useful the drug is. So that's why an intent to treat analysis is always the main way of looking at things. But you might also want to know the answer to the question, well, what if I did attend all or most of my sessions? What might I expect then? So you can get the answer to that in this next slide, where the right-hand bars are showing this secondary analysis that was looking at or allowing for the effect of the degree of attendance of people at their lessons or acupuncture sessions. So this analysis, which is called CASE, or Complier Average Causal Effect, is looking at the results, but only for those participants who attended at least 3/4 of their Alexander lessons or 3/4 of their acupuncture sessions. So not surprisingly, these reductions in pain and disability they're greater than we saw we can see in the intent to treat analysis. So in other words, if you attend most of your sessions, your outcome's likely to be better than if you attend fewer of them.
Mm.
And you can also see in this analysis that the Alexander lesson group is kind of nudged ahead. And I think perhaps you can understand why if you look at the actual attendance figures. So overall attendance was quite good compared with other trials. So 72% in the acupuncture group attended all of their 12 acupuncture sessions. And then a bit less than that, so 60% of participants in the Alexander group attended all of their 20 lessons. Maybe that's not surprising. It's more of a commitment to attend 20 of anything than it is to attend 12 or something.
Mm.
But also, if you look at the proportion of people who didn't attend any, this was 6% in the acupuncture group, didn't go to any of their acupuncture sessions. But it was twice that amount, it was 12% in the Alexander group didn't attend any of their Alexander lessons. But their outcomes would have been included in the main intent to treat analysis as if they had been to them. So, that's why it's useful to see both. It's not really very clear why there were more people who didn't go to any of their Alexander lessons and acupuncture. Maybe just because when people were expressing interest in the trial, maybe they wanted to be in it because they knew about acupuncture. Maybe they kind of hoped to be in that group, and then if they were allocated to Alexander, they decided not to. Or, who knows really, a range of things. But anyway, just useful to get that overall picture by looking at the two analysis, kind of side by side.
It is very interesting. I never really think about that, the fact that there's two different ways of thinking about it, and there's very different results, and the fact that people don't actually bother to turn up for their interventions. So is it possible to make a comparison of the results for reduction in pain and associated disability between the A-team sort of back pain trial and the Atlas neck pain trial?
Well, so the first thing to say is that you can't make direct comparisons between clinical trials, and well, especially if it's a different condition or a different outcome measure. So, with a massively huge caveat, you could make a few kind of observations. But sort of more generally, I think with the A-team trial, in one sense, the results were a bit more easy to relate to because there's one of the measures, which was the number of days in pain in the last month. And I think everyone remembers those kind of very striking results that following the 24 Alexander lessons for that group of people, they had only 3 days of pain per month, whereas it was 21 days in the control group. So that's that's kind of like a difference of about 86%. Now, for the Atlas trial, there isn't, the main outcome measure is not so easy to relate to as that. It's, the MPQ score is a measure of disability and pain, and it's much more, well, not much more, it's quite like the, same kind of idea as the Rowland Morris measure in the A-team trial. So it's perhaps not so kind of easy to kind of grasp the significance of the results. So with the caveat of you can't really do this, totally non-scientific. If you look at the change in the A-team in the 18 Rolling Morris, and you look at and compare that with the change in the MPQ score, then I think it was about 56% improvement in pain and disability in 18, and then this 31% difference in Atlas. So, you're getting good improvement in both, but yeah, it does appear to be more in the 18 trial.
Mm.
And I think you need to kind of bear a few things in mind here. You need to take into account, for one thing, neck pain is generally perceived as being more difficult to manage by doctors and other healthcare professionals than back pain. It's also relevant, I think, that the population in the Atlas trial was older. It didn't have the age cutoff that there was in 18. So I think the population was about 10 years older on average than in 18. And then the other thing is actually how kind of intransigent, if I can say that word, the problem was, because although the trial eligibility criterion was that you had to have had your neck pain for at least 3 months previously, in actual fact, the average duration was 6 years. So, this is quite long-standing. And I think the longest duration of neck pain that somebody had experienced was 50 years. So, it's quite a challenging kind of, if you like, population in terms of expecting to get a benefit. So the fact that actually there was a 1/3 reduction in pain and disabilities, I think actually quite meaningful.
Absolutely, very meaningful for the participants, I'm sure.
Yeah.
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 Okay. And so those are the main findings, I believe, from the Atlas trial. So next time, perhaps we can look at some of the other findings that arose from this very extensive piece of work. So thanks very much, Julia.
Thank you, Charlotte.